Okay, well, I think we're missing a few folks.
Almost the half, I think so.
Right?
Still,
Yeah.
yes, a lot.
Yeah, let me look. I mean, I know we're just a minute or two in, but yeah, we're missing some folks. Well, let me take a minute. Charlotte and Natalie, everyone knows you. You know everyone? Okay, here, Jack.
For the most part.
Okay.
It would be nice to hear everybody's introduce themselves if we have time for that. So.
We don't.
So then don't do that.
More, I wanted them to know you more, and then as they speak. We have lots to do, but I guess what I really wanted everyone to know was that Natalie and Charlotte are going to be here because they're excited about the course. They want to see what we're doing, but they will kind of fade into the background as we do our discussion. I want to make sure everyone feels comfortable to.
Hi, I'm Lisa. In this video, I will help you to fix 7 very common
get to learn something else.
English grammar mistakes. These
Someone
are
is
mistakes
sharing
that a lot of my students make.
their course that they have going on with them.
Let's see if you make them too. And I will
muting most of you. Okay, there we go. So yeah, I just want to make sure everyone's comfortable because I know we discussed a lot of things. Like last time we met, we discussed some of our weaknesses and strengths as counselors, and today we'll be discussing things like self-disclosure. So I just want to make sure that everyone knows that it's still a safe and comfortable space, and that Natalie and Charlotte are here just because they're excited about the course content and what you all are doing. And I don't want to presume, but won't be participating in the discussion per se. Is that correct? Okay. All right. So we're still missing a few people, but in the interest of everyone's time and respecting all of your time, I want to get started. So thanks to those of you who either put your assignment on the Universal Treatment Curriculum Forum on ISIP, or who contacted me if you had questions or comments about it. And it's fine if you didn't, because we can do that here. So today we're going to be talking, as you know, about key elements of a therapeutic helping relationship in addiction treatment. And Charlotte, now I feel bad. Do you want me to have everyone introduce themselves? Okay.
No, it's fine. We have limited time. I'm from INL, Drug Demand Reduction, for those of you that don't know me, and I'm really excited about this course. So thanks for letting me participate and listen in.
Thank you. We just last time went right up to the minute. There was a lot. So, and that being said, I have looked closely at the feedback that you all gave after the session last time. Thank you so much for taking the time to do that. I really appreciate it. And really great feedback, helpful for moving forward. There is one thing that I want to, I guess, challenge you about a little bit, and you can let me know your thoughts on this. A few of the comments, there was a little bit of a trend or a theme that you wanted to review the didactic more. So I'm going to challenge you that I think because we are really dedicated clinicians in this field and we care a lot about what we're doing, that we're always going to think we need more training. Is that fair? So I don't think that any of you need more didactic on some of these basic concepts. I could be wrong, but I'm going to have more confidence in you than maybe you have in yourself about that. So you've taken the basic UTC courses. You have a lot of experience. Fatima, that hit with you. I'm glad. So I think that we're always going to ask for more training. We're always going to ask for more because we're a really dedicated group, and I love that about you, but I'm going to challenge you that I think you know the didactic piece. You have the slides that I've sent you. You probably have your initial UTC course information. You have the didactic that is summarized in your participant and trainer manual. If I'm wrong, by all means, let me know, either here or offline. You can email me or contact me. But I'm going to challenge you that we're going to practice the skills rather than doing a lot more didactic or training of it. I don't necessarily know these, we talked about immediacy last week. Some of you said maybe that was a concept you weren't familiar with the term, but you were all familiar with, you were actually already doing it in your work. So I'm going to put a little more faith in you than maybe you're putting in yourself. And we're going to go forward without me adding a lot of didactic, because I don't think, honestly, I feel that would be almost a little bit disrespectful to the level of training and experience that you all have. You don't need me to tell you what self-disclosure is, right, that we're going to talk about today. So again, if I'm wrong, please by all means, speak up or contact me. And sorry to hear that, Jackie. She's having connection issues, but we're glad you're here nonetheless. So that being said, of course, I'm going to go through some of the didactic, but I'm really we're going to do some practice, and we're going to really dive into the skills. And if that's something you need more of, that's what we're here for. If you find that you're struggling with that because you do need more didactic, I'm here for that as well. So does that make sense? I know I'm probably supposed to just take your feedback and make the changes based on that, but I'm not willing to do that. I'm going to push back a little bit and challenge you, because I think I saw last time we met that you're all kind of hard on yourself. You're all, like you all talked a little more about your weaknesses than you did about your strengths. So I think you know more than you think you do, which makes you a really great group to work with. And I'm uniquely a bit, I'm probably uniquely poised to work with you given that case. So, okay, so that being said, let's talk about therapeutic relationships. It's really unique, right? I mean, a therapeutic relationship is so different than any other relationship in our life. And we can certainly use some of the same skills in therapeutic relationships with other people in our life. Hopefully we will use, some of the things we talked about last time, like empathy and warmth and immediacy. But then we get into things like empowerment and self-disclosure and dual relationships and transference and countertransference. Fatima had a really, really excellent question that we'll come back to later about transference with people who you're not doing counseling with. And that was really interesting and definitely made me think, and hopefully some of you as well. So we know that essentially what we're trying to do when we're counseling is to empower the people we work with, right? We don't want to do it for them, which is different from a relationship with children or maybe with other people in work environments. And we want to teach them how to handle the challenges that they're absolutely going to face given their situation. So we want them to have the confidence and the skills and the power. And I guess in a way, that's what I'm doing with you as well. I want you to have all the skills and the confidence that you can do all the things that we're talking about throughout this course. We're going to talk more about self-disclosure. So this is something I'm sure a lot of you have struggled with and had, interesting conversations with over the years in your field or in your employment. I know I have. I've had bosses that said absolutely no to self-disclosure. I've had ones who said self-disclosure as long as it's benefiting the client. I've had people who worked under me who really shared more than they should have. There's a lot of different things, so we'll go into some of that. And then transference and countertransference. I think I'm really grateful for these terms because I think sometimes it's scary to admit that we're humans. And even though it's a counseling relationship, we're still going to have our own emotions come up. And Lilia gave a great example last time where she had a former colleague that ended up being in her care. So you're not a human if you don't have emotions when that comes up, right? We're going to. So it's a matter of how do we handle it. And, maybe if we have countertransference, that's not the right person to be on our caseload, but maybe it's an opportunity for us to work on certain things. So, there's different ways to look at it. So was everyone able, I don't want to forget nonverbal communication. I really, really loved what Fatima wrote on the forum, and I hope some of you were able to read it, about how important it is to know the culture you're working with, if you're working in a culture that's not your own, or just individually when you're talking about nonverbal communication. Because I could come to you as someone who grew up and was trained in the States and say, well, you need to look them straight in the eye when you're speaking to them. And there's a lot of places in the world that would not be well received, right? So, that's just a basic example, but it's really important. And I'll tell you, we're not going to spend you know, we could spend hours and hours on cultural competency, right? But one thing I will just encourage you to do is to be comfortable asking. So if you're with a client whose culture you don't know and you're not comfortable with, or you haven't worked with before, sometimes it's just a matter of asking them, you know, is this okay so far? Are you comfortable with how I'm presenting? Do you have any feedback for me? Whatever it is. And again, we have to get rid of ego when we do that, right? And I feel like you're all really good at that, which again is you have a leg up in that way. Because the fact is, we can be really confident about a number of cultures, but we're not going to be culturally competent about every culture that we could come across with. And people are individuals. So what works for me may not work for someone else, just because, I mean, the United States is a great example, and I'm sure it's like this in a lot of your countries. Just because something is okay with me as a white female who grew up in an urban center doesn't mean it's okay with a minority male who grew up in a rural area. We're not the same. We don't have the same experiences just because we grew up both in the States. Hi, Veronica. Welcome.
Hi,
Glad you're here. So,
my pleasure.
so let's talk about our assignments that we worked on. Who was able to meet with some of your clinical supervisors or colleagues, whether it was virtually or just through discussion? So who wants to share? Let's start with dual relationships. What were some things that came up when we talked with our team about dual relationships? Ameza, you want to start?
Who, me?
No, Ameza's going to start for us.
Okay.
Oh, okay.
Yeah.
So, yeah, we have a center. It's an inpatient facility where we manage patients with substance use. And for therapists in that center, the issue of dual relationship, it's something that we always come across. Funnily enough, just this week, we had a scenario where a therapist was managing, had to, well, not, it was an accidental, they match therapists to clients. And somehow this therapist ended up with a client that was the pastor in his own church.
Oh
So
my.
it came up and we had to discuss it as a team. It was a bit
Oh, you're breaking up, Ameza.
It was resolved that this to generate.
Okay, sorry,
Can you hear me?
we lost you in the middle there.
Okay, can you hear me now?
Yes, now it's clear.
Okay. So that was a fair funny scenario, but at the end of the day, it was resolved that this particular client should be given to another therapist, and that was how the team was able to resolve it, and
Right.
we moved on from there.
Thank you. And I think when the dual relationship is the other way, like you knew them before and then they come into your treatment center, sometimes that's the easier answer, right? They can move to someone else's caseload if that's available, if it's a large enough clinic and things like that. So that's a nice example to start with. Who else? Fatima, did you want to share an example?
Yes.
Yes, okay.
Can you hear me now?
Yes.
The network is bad here. Yeah, but can you hear me?
Yes, ma'am.
Yeah. Like, when we're talking about dual relationship, like the example I gave in my write-up, I used to have a client that that I later, got to know that is going to marry a friend's sister. So that was about 8-9 years ago when I just started the counseling job.
Mm-hmm.
So when I saw him at my friend's house, I was, I didn't know what he came to do. I thought he was their relative. I greeted him, but later in life, I got to know that I'm not supposed to do that. But I greeted him. I said, "Hi, how are you? How are you doing? How are you coping? You know,
Yes.
how are you coping with your recovery?"
Right. Yeah.
and
Yeah.
and the guy was not comfortable really. So I saw that he was reluctant to answer my questions, so I let it be. So when
Right.
I got back to the office, I told my supervisor, a lady, I told her what I saw. And she said, "Was that what you asked your client in the presence of see?" I said, "Yes." Then she said, "Oh, you didn't do well. I shouldn't have done that." You know? So at the end of the day, I had to transfer the client to another counselor because it wasn't easy. He was in recovery. He was trying to change. You know, sometimes he relapses and he comes back. So it wasn't really easy for me as a counselor. So I decided to transfer him to another counselor. So I found out that dual relationship is not really easy. Sometimes it's unavoidable, but
Yes.
it's not easy to cope with when you are working with your client. It's not easy at
Right.
all.
Thank you.
Yeah.
And I think it's really important you bring up the idea of being unavoidable, especially, you know, in small areas where people may serve dual roles, like Omeza's is a great example. If they're, you know, the pastor of your, you know, do you have to change faiths? Do you have to change religious institutions? I mean, that is a huge ask of anyone. And it may not even be possible. There may not be another church in your area of the same type. So sometimes we don't have the choice to just switch it out, so to speak, right? So what do we do then? When we can't just, yes, maybe we move them off our caseload, but nonetheless, we're still going to them as a pastor or as, you know, the only person who sells something in your area. What ideas do we have on how we would handle that? Shigeo? We'll wait for you to unmute.
Okay, so I think many times dual relationships is the first approach of many people. I think it's due various factors. Appointments in the public system here in Mexico are very far away. Sometimes there's a crisis, emotional crisis emerge, and they need to have a quick assessment. Sometimes people feel identified after I gave how you say, a conference or a talk in the community. So they approach as the close friends of my
that's
my
a good
life.
point. That's a good point.
They learn about mental health because I'm a psychiatrist. So sometimes my talk is about mental health.
Sure.
And they approach with me because they identify some of their families, but I'm like a member family of them. So
Right.
sometimes that's a dual relationship.
Yeah.
What I do in those situations is that I listen to them, I validate. Sorry about my pronunciation. I
No, it's
validate
perfect.
them, okay,
Perfect.
and I give an opinion, some kind of clinical orientation of what might be the problem, and then I generally, how do you say, transfer to other colleagues, or sometimes if that's a crisis, I mean like agitation, suicidal ideation, something
Yes.
very big.
Yeah.
I say I give many direct orientations, maybe some psychopharmacology in that moment, but just for that, I make them clear about my intervention, that I'm their friend or their colleague, not their
Right.
counselor or something. And
Right.
that's maybe
Yeah.
the way I do it. Yeah.
Thank you. Yeah, so sharing resources, sharing other things that can be done for that person is great. You know, Veronica, go ahead. You just have to unmute yourself, dear.
All right.
Yes.
I said, just like Shigo mentioned,
is a very difficult thing to handle.
Mhm.
Most times people come to you and they are a member of your church. Like recently I was referred somebody that is a member of my church to me. And the first thing I said, look, I can't do this. I'm going to refer you to somebody else because this is going to be a kind of dual relationship. We fellowship in the same church, and I'm going to do therapy for you. From my own understanding, it will not work well. You know what he said? He said, if you're not going to help me, I'm not going to go anywhere.
Oh.
I'm not going to anybody. So you are just rejecting me and telling me not to have therapy. So then let me just be. So that was what he did. And I said, okay, for us to enter into a relationship, which I find very uncomfortable, I'm going to give you all my rules that guide this relationship. And you are going to promise to abide by it all. And he did. And somehow, it did work well. But I told him at any point in time in our therapeutic relationship, if anything goes wrong or happens to change, I'm going to refer you to somebody else. So it's kind of very, very difficult sometimes for you to avoid.
What an interesting example. Thank you.
Yeah.
So, I mean, so many things come to mind. I see a lot of people are responding with, you know, with their nonverbal communication. I mean, first of all, that feels pretty manipulative. I feel bad for you, right?
Yeah.
You know, that's the first thing. And yet at the same time, our hearts, we want to help, right? And that's what, you know, so I'm going to give some ideas and feedback, but please don't take any of this as a criticism of how you handled it, because maybe some of these options weren't available to you. It's just general. You know, one thing that I want to make sure, because I haven't heard it yet, is we have to talk to our supervisors.
Yeah.
Right? We have to talk to our team and our leadership, because one thing that, even if it's just from a standpoint of covering yourself, it's never going to look good if later someone says, oh, that's your pastor? Oh, that's your friend from church? Oh, that's your, and you've never told anyone, right?
Yeah.
So, so from the standpoint of protecting yourself, first of all, that's really important. Secondly, they may have ideas that we don't have. I mean, that's one of the things I love about working in this field, is that I have always worked with these great multidisciplinary teams and with people who think differently than me. And so, like, Shigeo comes from a mental health perspective, where I come from an addiction standpoint. If we were on a team together, his knowledge base is going to improve my knowledge base. So if I bring something as a concern, he might say, have you thought about this? And I'll probably be like, nope, you know, and so it helps. So in that case, you know, another thing, Veronica, would maybe be, I really want to get you help, come to my center with me, and then maybe you try to do like a warm handoff to someone else. You know, because the other thing to keep in mind is we can't take it on for everyone, right? That's ultimately, if that person said to you, I'm not going to do it unless you do it, and you put a hard line because you didn't, you know, that was your policy or your agency's policy on dual relationships, that would be okay too. It would be painful and it would be hard to do, but it would really be okay. So I guess I want to give you that permission too, you know. It's difficult. One example in my life is I had some work done on my house, and it was a huge job. They were redoing the floors, you know, it was all this, workers were in and out of my house for a long time. It was expensive. And when we went to settle the bill, it was less than I expected, like significantly. Not that I'm ever going to complain, but I was surprised, right? And the person said, Miss Carey, you don't remember me. And the only people who call me Miss Carey are in the treatment center. So I was like, what? No. And it turns out it was a former client. And I had no idea. I hadn't done counseling with that person. I had run the facility. So I didn't remember the person, and they were trying to give me a huge discount because they knew me and because I had helped in their treatment. And I couldn't take it, you know, and it was, you know, thousands of dollars kind of thing, you know, you would like to be able to, but, you know, what if that person comes back to treatment, like was mentioned, you know, Ameza mentioned, you know, relapsing. This is a relapsing and chronic disease. People come back to us. We can't pretend that the relationship is just over. So, you know, that's another piece to keep in mind, that things like that come up. Even small stuff. I've had clients where I go to a restaurant and they're like, oh, Miss Carrie, that one's on me. And I'm like, nope. You know, part of that's just keeping your integrity and keeping your, you know, what if that person then comes back into treatment and gets in trouble and is like, you're going to discharge me after I gave you that free meal, or after I gave you that thousands of dollars off your, you know, I'm not putting myself in that position, you know, so I'm going to be above reproach when possible, you know, but some of these are more complicated situations and we certainly can't solve them all today, but that's why make sure you go to your team and your supervisors. You are not expected to handle this all on your own. And there may be policies in place where you're working as well. Okay, I know this is such a great active participatory group that I know we could talk about all of these things at length, but we'll have to move on to some of the other pieces. So let's talk about self-disclosure. Who would like to open the conversation on what they learned by talking, either by their own experience or by talking with peers? Yes.
Yes. When I started in the counseling field, I was insecure to self-disclosure because I don't know if it was appropriate or not. But
Yes.
at present, I use a lot self-disclosure because I work with Latino population.
Mm-hmm.
So Latino population don't have a linear conversation. We don't go from point A to point B. We navigate in different systems. So self-disclosure help the clients to be more open to disclose their own issues.
Sure.
Yeah. And the other thing that I was talking with my colleague was some of them work in a residential treatment.
Yes.
And they say that self-disclosure is a normal thing every day. They disclose more in a residential than an outpatient service.
Yeah.
Also, they say that the dual relationship is more common in residential treatment than outpatient program. I don't know, nobody mentioned about dual relationship between supervisor and supervising.
Oh, good point.
Even though we have a very strict policies about dual relationships in the job, is an issue that normally is not reported.
Yeah.
But self-disclosure, I feel very comfortable. I always ask myself, is the benefit for the client if I self-disclose or no? I ask question, what is the benefits of the client or no benefit before to disclose? And also, if the disclosing has an emotional charge, I don't disclose. I really avoid disclose any too much emotional things.
Yes.
I just try to avoid it. Mm-hmm.
And I love that all of you have brought in cultural pieces to it, because that's a great example. You can't, if that's how conversations work in your culture, you can't completely get rid of that because no, I'm the professional and I can't, you know, I can't share anything about my life because, you know, and the other thing is, you know, you have a picture of your kids on your desk or something. And if they ask you, what are you just going to be like, you know, we have boundaries, but we also have relationships. So I think you brought up some great points. My favorite being, does this benefit the client?
Yes.
Because
for example, I am an immigrant, so when the client is coming with depression and anxiety and adjustment disorder because they just come to the USA, I normally self-disclose how to handle these things. So, and also normalize all the behavior, all the feelings of the emotional as an immigrant.
Yes, so normalizing and providing hope, because clearly you're successful and you're well, right?
Yes. Mm-hmm.
So as long as that conversation doesn't then become primarily about you.
Exactly. It's not about me. It's to help the client.
Because it goes back to empathy. I may or may not have had the same experience that, you know, Jackie has had, but I've felt fear or I've felt anxiety, or in this case, I've felt something a lot closer to what you felt because I am, you know, if in your case, because you've been through the status of being an immigrant, you know, so I think there's a real benefit to that. Now, I will tell you my personal experience. You can tell I'm big on self-disclosure with y'all. So I personally, when I started was very tight-lipped. And the reason was because, well, part of the reason was because I didn't think I could relate. And I thought that they were going to call me out for that. And they often did. Well, what do you know, Miss Carrie? You're just, you know, you haven't been addicted. You haven't been through this, you know, until I realized and had enough confidence in myself that, no, maybe I haven't been through your exact experience, but I've been through pain. I've been through fear. And also that it's really okay to say, you're right. I haven't been through exactly what you've been through. And that's okay too. I can still be a good counselor to you. And to also to talk about your residential point, that's where my my years of experience were in residential. And you're right, there's a lessening of a boundary. I think you know, obviously you still want to strongly have a boundary and be appropriate, but you know, you're walking in and out of that person's home all day. And you're seeing them at, you know, at odd hours and at, you know, their worst and different things. And so there is a little bit of a level of where that boundary is just, you know, obviously still want a strong boundary, but there may be a little bit of a lessening at times. You know, and there's a back and forth debate about self-disclosure of people who are in recovery. Right? So some people feel that, well, I can be a really a stronger counselor to this person or a stronger support to them because I'm in recovery. But then obviously there's this argument from the other standpoint of, well, there's lots of people who aren't in recovery who are doing really great work as counselors. So some people I know who are in recovery have the strongest boundaries and don't share their personal experience because they don't want to, again, make it about them. So I think keep in mind your organization may have certain, as I said, I had a CEO who was no self-disclosure, nope. And I've had other leaders who were, if it's appropriate, if it's, you know, for the right reasons. Veronica?
All right. Talking about the issue of non-disclosure, I think we had a bit in the center where I work, and it happens to be a residential and maybe outpatient. But the residential, we have to be very careful when it comes to issue of self-disclosure. At a point, it was business as usual. You can self-disclose until it comes to a point that a younger counselor who had a problem with sickle cell disease anyway. So during one of his sessions, he had to kind of self-disclose to the clients, oh, this is the way I cope with, I know I have had to abstain from pentazocine because it was causing problem to me and all that. So after the class, some personalities of clients use it as a point of taunting him. Oh, this sickle cell person. Oh, so he was so embarrassed that he stopped coming to sessions. So we find out, and now, no, this was so bad. So we have to bring out a policy, especially for the young counselors. No self-disclosure, especially at the early stage of your counseling session. No self-disclosure, except maybe towards the end. That is if actually it is very, very necessary. So with that, we have been able to use that to serve as a kind of basis for our counselors, whether you are old or you are young or you are new. And since then, I think we have had a balance. Thank you.
That is such a great point. Thank you. I didn't even think about the fact that it does make you vulnerable, you know, which can be great. It can be brave and courageous and wonderful to be vulnerable, but it can also be, you know, betrayed. That vulnerability can be used against you. So thank you for that. Okay, so again, we don't have, Julia, go ahead. I think you're, yes, please.
Julia or me? Julia, just to make a comment. Also, we have issues with self-disclosure between co-workers.
Okay.
For example, some people are sensitive. I have one child treatment. She is Jewish. And another psychiatrist just let a client know that my coworker is Jewish and this client is from Palestine. So it was a very conflict because it was a political sensitive topic between
Yes.
a Palestine client and a Jewish counselor, just to like make a comment that we had to be careful because sometimes another coworker can self-disclosure about.
Right.
I was thinking about how important is to be really clear about the role that I'm playing in the relationship. There is an expectation about how I play this role, and my role is to be a counselor. I think that we have to be really aware about the responsibility of our role. I think there is an ethical issue, and we must be really aware, thinking about something that that Judith said. We must be always sure that our self-disclosure is for the best of the client.
Yep, perfect. Yeah, and like Julie said earlier, I didn't comment back on that, but the emotionality. If you're bringing something because something just happened and it's fresh this morning and now you're going to go into your session, it's not your counseling session, right? It's not for you.
Yeah.
So you're right. The responsibility and the ethics of it are huge. And, you know, and you'll notice I'm not talking about things like dual relationships as in sexual dual relationships or self-disclosure as an inappropriate self-disclosure, because again, you guys know those. I'm talking about the more complex, sophisticated pieces that we sometimes don't know how to handle or that we struggle with. So obviously those other things exist and we're aware of them, but this is more on that level of things like what Veronica said, you know, that person who says, well, I won't go into treatment if it isn't with you. You know, you don't see that in a lot of textbooks. How on earth do you handle that? So thank you. Okay, so I'm going to mix things up a little bit for a second and we're going to do a role play. So I need 2 folks who are willing to role play, and I'll help you, and we'll all be, Fatima, thank you. We'll all be kind, I promise. So could I have a male participant or volunteer? Shigeo, thank you. So Shigeo, I don't know if you like acting, but you get to be a creep today. You get to be a little bit, you know, you get to hit on Fatima. So you guys are going to be in session, and you're going to basically be deflecting whatever she wants to talk about in session because you want to know what kind of men she likes to go out with. And then Fatima, how would you handle that with him? And any feedback that we give you obviously is going to be constructive and positive and, you know, in no way critical of how you do, especially on the spot. So let me make sure you're unmuted here, dear. So Shigeo, do you have on your creepy hat? Are you ready to be inappropriate?
Oh, okay. Well, sorry. Can you explain me again the instructions?
Yes. So you've been...
Just to have it very clear.
Yep. But don't worry, you can't get it wrong. So Fatima is your counselor. And in the past, you've asked her things like, are you dating anyone? And she's kind of just dismissed it. Today, you're asking her what kind of men she likes to date, and we're going to see how she wants to handle that. Assumption being that there's some potential, obviously, dual relationship issues, self-disclosure issues, and transference.
Yeah, I just
Can you repeat again because we don't hear well?
Yeah, it was an audio problem.
Okay, sorry about that.
Okay.
So, Shigeo, Fatima is your counselor.
Okay.
And you have basically asked her prior what kind of men she likes to date, or if, you know, you've been inappropriate, and this time you're going to ask her, you're going to ask her what kind of men does she like to go out with, and then she'll...
Okay.
And then we'll see how she responds.
Okay.
So Fatima,
Hello, Fatima.
you can start your
Hello, girl. How are you today?
Yeah, well, it's a very hot day today, you know.
So you are welcome.
Thank you very much.
Yeah, I'm
There's
a
been a lot
counselor.
of things. Sorry, there was a lot of things this week I
Okay.
would like to share.
Okay. Tell me about them.
Well, I have a friend of mine that has been struggling with her boyfriend. So I know I think they kind of have a very big argument. I don't know if there was a physical fight between them, and
Okay.
that get me very stressed about it. And I know when I'm stressed, I'm thinking about my mind just pop and tell me to get back to drink.
Oh, really? So, what happened between your friend and the girlfriend? What was it? What was their problem about? Was it a problem that's directly affecting you?
Well, in the past, I have some feelings with her, so I know that's kind of, I don't know what was the problem, so I just have feelings for her. I think that, yeah. So what do you do in those cases? I mean, what kind of men do you like to date?
Okay, Mr. Shigeo, I would love that.
Oh, we lost your audio for a minute there, Fatima. Are you there?
Talk about the comment.
Okay.
Isn't that what you said? Feel about your friend's relationship and the lady. What do you feel about it?
Well, she's a very kind person. Yeah.
I mean, your friend. What do you feel about your friend dating the lady?
Well, I think she's very special, and I know that make me feel some kind of positive emotions to her.
But will you be comfortable that your friend is dating her while you still love her?
I know.
So Fatima, thank you guys. So I lost you a little bit there, but it sounded like you were redirecting. Is that fair to say?
Yeah.
So you were redirecting away from him trying to. It sounded like you were redirecting away from him. Okay, great. So redirection is definitely one way to bring it back to the appropriate conversation that you're supposed to be having in a counseling session. Great. What are some other things that people think that you could do in that situation? Is there anyone who would sort of directly address it?
I like the way Fatima do it. I mean, this they kind of like make it direct. Like, okay, I hear that, but you were talking about something else. Mm-hmm. I think that was very smooth.
Yes.
Many times, many clients will respond that way. Don't they know that that's not that was not I know the direction to go. So
I was just thinking
we
of me telling
move
Shigeo the
that
kind of men I
direction.
go out with. So,
I'm sorry that we're having some issues with our audio today, and with our, it's a lot of people on the network. But thank you for bearing with it. And I agree, that would be amusing, Fatima. Like if you were just like, well, so I normally like guys who, we're gonna put that in the not the way to handle it column, right? But you're right, Shigeo. I appreciate the compliment and the feedback to Fatima. It's she was very, I missed a little bit of it because of the audio, but seemed very smooth, like moving away from, and that's definitely one way to do it, is to redirect. Now, what if maybe Omeza, I know you have a comment, so actually why don't you go ahead before I ask my question?
Yeah, sorry. So I think Fatima did well. She not only directed the question, she took over the conversation and tried to, as the counselor, instead of getting carried away or getting angry, she did not, she didn't, scold him, practically explained to him that it was not appropriate for him to have asked that question without hurting his feelings. So I think she did well.
That's a great observation. Thank you. So what would happen to the relationship if she were to say, that is completely inappropriate. You shouldn't be asking me questions like that.
I think the client will feel offended and the client will feel cut away from me. He will feel
Right.
I'm not ready to help him.
Right. Right. We can't expect that the client behavior is always going to be perfect. And we know that some of these things are defense mechanisms, right? So maybe he wants to talk about it, but he's kind of ambivalent, and, it's easier for him to, and maybe he is experiencing transference where you're a nurturing presence that he's like, oh, maybe I'm interested in her. He may not have had relationships in the past where there's this mutual respect. So that can seem like a relationship rather than a counselor. What though if he kept pushing? Shigeo wasn't like a really extreme kind of, he's a gentleman, so.
Maybe like a stalker.
Right. Right. So what if, Veronica, you have a thought on that?
All right.
Yes.
All right. There are some clients with what I call some kind of personalities that might come out all on you, kept pushing just to get at you, especially for those who were forced into therapy. They might want to get their way. And what Fatima did was actually great. That's to change focus immediately. But there are some clients who might kept pushing, but as a counselor and that understand that this thing must we kind of navigate it just like Fatima was doing, and keep on facing the right track that you are facing, and not veer the way. Or if you think that you cannot go on, I think at a point you can say, okay, can we have this discussion some other time? And you kind of civilized way end the therapy and continue some other time if you cannot cope with it, because there are some people that might not be able to cope with the pressure at a particular point in time. Thank you.
Thank you. And Easy? Yes, go.
Okay. I think the presentation was quite awesome by Fatima, and my friend Shegu. But I think I will have to add this. Just like Veronica said, some clients might be pressing and pressing and pressing. I think in addition to what Veronica said, the therapist or the client or the counselor, as the case may be, ordinarily could have exposed the client other alternative ways, different types of men some ladies would like to date without directly it to herself. For instance, you have said maybe there are different types of men or different kinds of men ladies like dating. She may give instances of different kinds of men without particularizing it to herself. Reason being that if there are some clients, if you fail to answer them, then they may get upset. And at the end of it all, you may lose the therapy. So it is pertinent you carry them along so as to enrich them. Thank you.
Thank you. And I think that it's really okay, especially if that behavior continues.
I think I've just meant,
I think it's really okay, especially if that behavior continues, to have not a scolding conversation, not a emotional conversation, but a direct conversation, right? So I've noticed that in the last 3 sessions, you've asked me some personal questions.
Hello? I can't hear you.
Oh.
Hello? I can't hear what you're saying, please. No, I can't, please. Come again.
Okay. Can anyone hear me?
Yes, I can hear you.
Okay.
I can hear you now.
Okay.
Hello?
Yes.
Hello, can you hear me?
If you unmute yourself, Eze.
Okay, can the rest of you hear me? Can everyone hear me? We were so fortunate last time we didn't have these technical difficulties, but I guess it's to be expected. I'll repeat, I was saying that I think it's okay to have a conversation with a client that you're not scolding them, you're not being overly emotional, you're not reacting, but you can say something like, I've noticed in the last 3 sessions, you've asked me some personal questions. I really want to make sure that this time is for you. You know, you have an hour a week or whatever it is, and that time is really for you to talk about what's going on with you and not for me to talk about me. You know, that's one way you can do it. That's really, it's direct and it's assertive and it's appropriate, but it also puts it right out in the middle. Does that make sense? Okay, can everyone hear me? Thumbs up.
The audio is not good.
I'm so sorry to hear that. I'm not sure what's going on.
Yeah.
Maybe it's a global issue, you know?
Yes.
All the planet is using Zoom right now.
That's true. That's true. As I say, I think we were very lucky last time because we're having a lot of issues this time. And well, I apologize. And one of those things I'm powerless over, despite what my desires. So that being, given that example, let's talk a little more about transference and countertransference. And this can be difficult to talk about because we have to be really insightful and vulnerable about ourselves to share, especially if we've had countertransference ourselves. Maybe an easy way to start looking at it is, are there certain clients, certain types of clients you've dealt with who bring up an emotional response for you?
Can I ask a question?
Yes, please.
Yeah, if you remember in my write-up, I was talking about transparency, and I asked that sometimes people just see you on the road, they think you are someone else, and they say, "Oh, Carrie," somebody just hugged me and say, "Oh, Carrie, how are you?" And I'm not Carrie, and the person looks at me and said, "Oh, you look like Carrie. Are you not the one who went to so and so school?" I said, "No." Are you not the one that? I said, "No, I'm not the one." Is that transparency?
That is a great question. Does anyone want to answer that or give their 2 cents on that?
Can I answer? Can I answer that? Yeah. Story. Carrie.
She turned off her camera.
Okay, we are having network problem. I think in this context, transparency has to be in the context of a therapeutic relationship.
Good.
Yeah, transparency only comes up. It has to be in the context. So you should be in a relationship with a therapeutic relationship with, say, a therapist and a client. In the course of this relationship, then you can have transference. That is, the clients now having feelings towards you, or counter transference, you having feelings towards the client. So the example you gave will not fit for the transference because it has to be in the context of a therapeutic relationship. I think that is my own understanding of it.
I have another question, like Fatima, I have clients that talk about Black people. Mm-hmm. A lot of negative in all my culture, and I feel I don't demonstrate the client that I don't like it, but I feel very disappointed with him. I don't know if that is counter-transference or not.
Can you guys hear me okay?
Yes, we can hear you.
Okay, great. Sorry to not have on my video, but I'm hoping it will help. First of all, that was perfect answer, Omeza. Thank you, because it's very unique to a counseling relationship, transference and countertransference. And Julie, with your question, I think that's just human disappointment. That's just feeling, you know, let's dive into what transference and countertransference really are. So transference is, I mentioned earlier, the client may see you in a different way than just a counseling relationship. Perhaps they didn't have a nurturing mother, for example, and you're a female figure.
Yes.
Perhaps, you know, they are looking for a stable male partner and you're more of a, you know, you're a male figure. So it's more of they see you in a way, they're taking desires, feelings, needs that they have that aren't really appropriate to put on your counselor, and they're doing that. And sometimes it's just because you have a good relationship. It's not necessarily a negative thing. It just depends on how it's used or handled, if that makes sense. And countertransference is the opposite, right? So I have feelings and needs and desires as a human being. Did you hear me about countertransference? Okay, so
yes,
okay, so as a counselor, I am still a human being. I go in as a human being every day. And if I am meeting with Julie and she reminds me of my sister, and I have a very poor relationship with my sister, perhaps I try really hard to repair. Essentially, I'm trying to repair my relationship with my sister through my relationship with Julie. So those are the kind of things we have to be careful of. And it's very unique, as Omeza said, to a counseling relationship. It's not going to happen in a, you know, casual or friendship or things like that for the most part. And as I said, it's not that it's a negative or bad thing, we will feel these things. It's a matter of how do we handle it. Our clients will feel these things. It's a matter of how do we then handle it with them. So that's why I said there may be some value in presenting some things directly, especially if it's very clear to you that that person has some transference, that, you know, maybe you slowly but directly introduce that concept of transference or countertransference, so they can understand that, oh, maybe I'm missing a maternal figure in my life, or maybe I'm missing, you know, whatever it may be. Questions or comments on that?
Just a comment. As you mentioned, a client, I work more with immigrants people, so they tend to see the counselor as a mother or aunt, not because they was in childhood, they have not have a mother, it's because the nursery, they see that we have respect, we have compassion with them, so they tend to see us as a mother. But always I say to the client, okay, if I can be your mother, but if I am your mother, who will be your counselor? So they just laughing.
Right. That's a really
that's very simple way to handle. Or I can be your friend, but if I am your friend, who will be your counselor?
Oh, I like that. I like
they
that a lot.
understand, laughing, and that is the best way that I handle it.
Yes, excellent.
Yeah,
Excellent.
that's good.
Yes, Shigeo?
Okay, I would like to highlight some of the points of the from the manual. There's a point that says the counselors model a healthy relationship for the client. So we have sort of repressing some impulses, and we are trying to give our best. And we have another point, we have the responsibility to engage the client and assist in the retention treatment. So that kind of combination of the attitudes, I mean, there's always going to be transference and counter-transference. And in that scenario where we're acting conscious to express that kind of attitude and kindness, I mean, it's very powerful. We're always trying to make rapport every session. So many times we're going to be maybe the only human being that is very consistent, very trustful, and that kind, how you say, may confuse the client. So I think at some point it's a sign of a good relation, a good work in the counseling, and it's our duty to explain them so they don't misunderstood that transference. And I think it's kind of a good sign, and
Yes.
it's inevitable of the process of working with this.
I could not have said it better. Thank you. That's absolutely perfect. Perfect. And that's why I say it's not, you know, I don't think we should perceive any of this as negative. But we need to learn from it, right? If we just kind of dismiss it, then as you say, they don't learn, oh, I think I'm attracted to, or in love with, or friends with, or whatever, my counselor, because I haven't had relationships like this in the past. Veronica, did you want to add to that?
Yeah, I want to say something. And just like Shigo said, transference is very important in a counseling relationship. There are some feelings, somebody verbalize it and we might not see it directly. But if the counselor or the treatment team is watchful, they might know that this is what the client has been going through as he displays it through transference. We had a particular client that when he came in, he was assigned a counselor. He was highly irritable, antagonistic towards the counselor. He doesn't want to listen to the counselor. He was always opposing to the counselor. At a point, he said he wants to leave the treatment. So we have to sit him down and find out what exactly was the problem. He said, no, that woman, she acted exactly like my mother. I don't want to listen to her. She's this, she's that, she's that. So with that, we were able to find out what exactly the problem was, and that he was having a very bad relationship with the mother. And that was one of the reasons why, or the cause, that was in maintaining his substance use. And that situation with him and the mother was resolved. But one point we took from that was that most times if we allow this transference to persist and we don't explore and find out the root cause, the client may leave treatment without getting what he actually came in for. So we decide from onset to allow most clients with some behavior or character or personality to kind of choose or tell us the kind of counselor they may want to be their treatment partner, or so to say. And at the end of it, I think we got a better result from our clients, and we learned a lesson from that. Thank you.
Thank you. I was smiling so big I had to turn the camera back on, so hopefully you can still hear me. But this is why I started the session today by saying, those of you who think you need more didactic, Ulia, bless you, you don't need more didactic. You are well versed in the concepts and have experience in them. But we're just here to sort of hone those and practice those skills, right? Because all of you could teach this. I don't know more than you. We just have this ability together to practice and think of things that maybe we didn't think of before because of our experience. So it's really exciting to me to be a part of it. Thank you. Now let's talk about countertransference. I think it's easier to talk about transference, right? It's easier to talk about when the client sees you in a certain way. It's a little bit scarier to talk about countertransference. And I'm going to open that up by being vulnerable and sharing with you all that my stepmother continues to be at this time a very active alcoholic. And my father was very enabling to her behavior, which, as you can imagine, as a child, and especially as I grew up and worked in this field, no coincidence, I'm sure, I began to have a lot of resentment and a lot of negative feelings towards that situation. So whenever someone would come into treatment that was, white female, alcoholic of a certain age, I had a lot of responses to that personally. That was not someone that I would suggest my supervisor put on my caseload. I would not be able to be boundaried. I would probably be resentful right off the bat for that person, just because it was too much like what I had experienced in my family. So the good thing is I was aware of it. Of course, not immediately, right? It took time to figure that out. And I was able to say, which is hard for us to say at times, I can't help this person. I think it's really hard for us to admit that at times, right? It's my own stuff. And being the kind of person I am, I would want to work on it until I could work with those clients, but I can't. That's just a realization I've had to have for myself personally. So I think it's really important that we have that insight in ourselves. And I wonder if anyone can share if they have if they've had an experience where they realized they were having some countertransference, or if they have something similar to my experience.
Yeah. Can I speak now?
Yes, ma'am.
Yeah. I have not had an issue with countertransference, but I have a colleague. She was dealing with a counselor from the university, a young man, very handsome, He had these dreadlocks. That is an hairstyle that you do with dreadlocks. So the boy looked exactly like her nephew.
Oh.
So when the boy came, she was like, "Oh, look at a handsome boy like you. How can you be doing this?" So after the session, I called her, said, "Why are you doing that?" He said, "That boy looked like that my nephew." Yeah. That was why, exactly, And unfortunately for her, her nephew was a boy that has some deviant behaviors too. So when she saw this boy, you know, she transferred the old feelings to the boy, and it wasn't easy for the client, you know. So she was telling the client, why are you having dreadlocks? Exactly like her nephew. And the next thing I heard the client said, my hairstyle does not define who I am. Why are you complaining about my hairstyle? You know? Yeah. So I quickly told my boss, and they came in and said, okay, Mr. So and so, can we postpone this session? Can you come back tomorrow? Is it okay for you? So I started talking with the lady. She said she was carried away because the boy looked exactly like her nephew. So sometimes counter transference it's not really good in therapy. And then we almost lost the client.
Right. Thank you. Excellent. Yeah, I think one of the ways you can tell that there's countertransference, if you don't realize it, is having those kind of sort of unreasonable expectations of a client, having, you know, your boundaries aren't as good, noticing, I think someone mentioned this in our earlier session, maybe Shigeo, like that emotional response of like, I really, like, why aren't they listening? I really want them to get better. And if they just listen to what I'm saying, they'll get better. And, you know, we can have that without countertransference, but I think it gets stronger if there's some countertransference with the client. Anybody have other examples? Yes, Lilia? Sorry, I'm nodding at you like you know who I'm talking about. I'm just like, yeah, you talk.
Thank you, Gary.
Thank you.
Thank you, Gary, first of all, for sharing your experience with this group. I think there is an important way when we were doing this course or with another group. No, I think it's a really valuable way of show how you experience. Thank you very much. Well, I remember in the treatment in Chile, it was usual for therapists in recovery from alcohol or drug use to work. I mean, it's people who has troubles with drugs or alcohol and now are working as counselors. Yeah. Usually they comment that was that no one could understand the problem better than them. However, I hear one of them speak once how angry he was with a client for having a relapse. This professional, I heard that he commented, I told him not to, that he did not together with friends with whom he consumed, because he was going to relapse, just like me, and he did it. The therapist felt that he and his client shared the same weakness, and the anger he felt at the client relapse was the anger he felt at his own relapse in the past. I found it wonderful that a person in recovery can help other person along this path. I think that's great. I think it's a real example of real integration. And however, I also believe that maintaining clear and healthy limits and boundaries can be especially difficult in these cases, as fundamental help is that which can be provided by the supervisors. You told it before. In Chile, it is not usual for the counselors to have clinical supervision. This is extremely expensive. There is a few professionals accredited as a clinical supervisors. However, talking as a team, I think that it could be a great support. Sometimes issues involving professional ethics are not so clear to everyone, not to me too, not to everyone. it is difficult to identify the boundaries, and another pair is required to help to look, to illuminate in a respectful, clear way, always.
Thank you. And you bring up a good point. Not everyone can have clinical supervision, or even, I mean, I've certainly been in clinical roles in the States where my supervisor basically didn't make themselves available for that kind of conversation, right? So sometimes you have to find a peer that you trust, or maybe if you're able to have your own counselor. You know, I know that's not available to everyone, but I highly recommend it if you can, because one of the things I love about this field is that our own stuff, I don't have a more clinical way to say that, our own stuff bubbles to the top when we work with clients and when we work in this field, which I think is amazing because it's an opportunity to improve ourselves, but we do need help processing all of that. And a team, you know, working with your team is a great way to do it too if you feel safe.
Yeah, we need a mirror.
Yeah.
Always.
Yeah. So, and this is a good opportunity, right? That we all have right now. Not everyone has. So, yeah. So I think another way to know that you are dealing with countertransference is if you start sort of giving advice rather than listening and asking the client what they think they need to do and looking at their options. When you get more like you would with like a friend or a partner, you know, when you're kind of telling them, well, what you need to do is, you know, then there's a good chance that you've kind of stepped over that line into countertransference. And I think road signs like that are important because it's really easy for us to not realize that's what's happening because we're just committed and we care and we want to do our best work. Which kind of brings us back to empowerment. The fact that it's really important for us to make sure the client is the one making the choices, right? And we can all, well, I'll speak for myself. I have slipped into, here's what you need to do, here's what's going to help you kind of territory, and maybe some of you have as well. But it's so important for us to empower the client that they have the tools to move forward to do what they need to do. And I really liked that, Fatima, in your writing, where you talked about you knew that this client had the right tools. We talked last time about people can tell if you're counseling them and you in your heart don't think they can change. They can tell that, right? And you guys would be able to tell if I didn't think you guys could do this work. It would be clear from my presentation. So we have to, you know, it's good to remind ourselves that we're empowering. Why do we want to empower the client to make the choices and do the next steps rather than sort of spoon feed them or do it for them?
Can I talk now?
Yes, ma'am.
Yes. You see, it's important for us to empower our clients to be able to determine self-efficacy. You know, the client should be able to know that he can do certain things on his own. It should be, the client should also know that he can take his own decisions, and whatever decision that he takes about his life is his own. It's not you, the counselor, telling him what to do. So in empowerment, it's very important because we provide skills for the client to be able to make the right choices.
Right. Yeah. Thank you. Julie, did you want to add to that?
No, I was also, I empower my client with knowledges like a skill set, for example. I have a client that she was in domestic violence for 25 years. And she came to my program because alcohol use. And I remember that she was very afraid. She was very dependent from her husband. She does not know how to take a public transportation. So we start with that because she has to work. She has 3 children. And I remember that when we was teaching her how to take the bus from the shelter to the treatment program, for her was a big step. Maybe for many people that was simple, but for her was a big step. And they start taking empowerment of it, like just with these simple things. Teach her how to take the public transportation.
Oh, yes.
And we normalize again the feeling. She was afraid, she was to get lost, she was very afraid. Now she is working, and she was not working, she was not taking, that is the client that I really remember that how we empower her. Yes. About 25 years in domestic violence with no friend, with no social support, with no family support. Right. Just the program, the treatment program was the only support. Wow. And we teach her many stuff. It's like it's teaching her to start walking.
Yeah, thank you. Izzy, did you have a comment? Hold on, Shigeo, you're after. I have one other. Yes.
Hello?
Yes.
Okay.
Microphone. Okay.
Can I go ahead?
Yes, please.
Okay. Just like Fatima said, it is quite imperative that we empower our clients. I had a similar example of this thing I want to talk about now. Just last week, there is this particular patient I am currently managing in our facility. Incidentally, the young man involved himself in so many things, including courtesan, drug use, and other nefarious activities. So in the course of my dealing with some of his problems, I made the floor open to him for him to give suggestions on a possible way forward. So, and luckily the guy was able to enumerate so many procedures, so many decisions upon which he's going to take to get rid of some of his challenges. And to my own judgment, I felt those outlined points were quite veritable. So, of course, in psychology, we believe those desired behaviors should be rewarded. Mm-hmm. That is positive reinforcement. Yeah. So I had to reward him in those regards and encourage him to keep it up, believing that it will help us to get rid of the problem. But I encountered a problem in the course of that. So during our ward round, incidentally, it was a huge gathering. My consultant, the head of unit where I belong, the residents, the nurses, and all other team members, we are all there. So in the course of our ward round, there is this particular point that my HOD suggested. According to him, he said that because the boy is involved in court activities, that for him to be able to get rid of those his court group members, he must break his SIM card. Whereas this boy is now claiming that his SIM card contains other vital information, that breaking it may deny him of so many other things. So I had to step in, which in the course of my discussion with him, I told him, since you said you're not going to break this, I also bought the idea, but you must keep these people at arm's length, which we resolved and agreed on how to go about it. And incidentally, there wasn't the whole thing. This guy, some of these court groups are in the same class with this guy, they are his classmates. And some of them are living around his vicinity. And my HOD insisted that this young man must break his SIM card. I asked him, sir, if this boy should break his SIM card, is he going to run away from his classmates? Is he going to leave the house where they are living, where majority of them are living around him? The most important thing is to walk up this boy, since he has accepted and has shown this high level of willingness, to forget this drug use. Let us encourage him in this area he has accepted to go back. Because if we must insist on him breaking his SIM card, it might be counterproductive. At the point, my head insisted. So obviously, in the course of all this argument, the boy now fled off. I had to tap my HOD, see what you are causing. The best thing, now he has accepted, and this is the only area he felt that he can go about this thing. Let's encourage him. So because I was trying to tell my HOD that there is need for us to empower these people. Let them be the one to be in charge to take this decision while we reinforce their behavior, instead of us making choices for them. So it is quite imperative, it is very, very important we allow the client to take decision. And by so doing, they will be able to do well. Incidentally, a similar incident happened. Somebody recommended his parents that there is need for him to go to a rehabilitation center while he was in prison. And because of that decision, and for him to have taken up that decision, then it is likely that the prognosis is going to be quite positive. So in sum, it is good that we empower our clients, because when we do that, it will ensure effective prognosis in the long run. Thank you.
Thank you.
I just add to a comment that, as Izzy said, it's like a process. Empowerment is a process to move the client from empathy or emotional validation to focuses on problem solving. He described very well. That is just a summary.
Yeah. You actually, I don't know if you see everyone there, you're getting a lot of claps. Yeah, that was really
I talk with my body.
Oh, yes. Yes, Titi. We haven't heard from you yet today. I need you to unmute yourself now.
Thank you, Carrie. Nice to see you again today. All right, I just feel that when we talk about empowering our clients, it's for them to take responsibility. So that it's not as if you're imposing things on them. They are the one choosing, making the choice. So whatever happens, they take responsibility. So we should teach our clients to take responsibility in everything they are doing. So it's not coming from their boss, but our own is towards enhance them, to reinforce them, to achieve their purpose. Thank you, Carrie.
Thank you. And, I like the point of, the fact is, here's one of the reasons that I have always been big on empowerment. You'll see that part of me is protecting all of us. If they don't like the results of the decision, I want them to take it on themselves, not blame it on me, right? So that's an important part of this. Yep. Dr. Godlove, did you have something you wanted to share?
Well, thank you so much. I think you just made that point, and I'm sorry for signing in late. I have had some difficulty with network today.
Yes, we have also had difficulty.
Yes, I was going to say, Kerry, that what the statement you just made is that I insist on getting my clients, empowering my clients, so they take responsibility for the success of the therapy, and if something is negative, they also take responsibility. But for many people who work from a faith background, sometimes they like to take decisions for others, and also at the end, they do not want to assume failures or the blame for that as well. So I insist on empowering my clients so that they take responsibility, they rejoice, they celebrate the success, and if anything negative, we are still in that journey, but they don't have to blame me for that. I think that's what you said, and I think I agree with that.
Well, and you bring up the other side of it, right? So not only do I not want them to say, oh, this is your fault, but I want them to really embrace when something goes well. If they got a job, if they got a healthy relationship, whatever it is, I don't want them to celebrate it. Yeah, that's not my success, right? That's their success. I want them to really feel that, and I think that's really important. So thank you. Shigeo, did you have a comment?
You know they can hear me.
The way I think about the empowerment is the process where the client needs to make conscious they are the source to where that positive energy rises, and that's the fuel that they need to make healthy choices, to keep the strength on commitment, focus. So I try to, it's like my compass that I try to make them conscious. You are the source of that kind of positive energy. You need to take, you need to arise from you, to have all the fuel you need to make all the process you have to do in that long, how you say, career,
Yeah, yeah, thank you. Okay, so it's funny, I want to talk now about nonverbal communication, and we actually had a funny example just today because I turned off my camera because of the problems with the internet, and then I was nodding and smiling over here and you couldn't see me, and I was like, I have to turn my camera back on. So it's so important, and you know, it's just critical. And as we've talked a lot about cultural competency today, we do know that it's going to be different everywhere. I've personally never had a problem. I've never had a client, regardless of the culture, who didn't enjoy the you know, a good smile and a clear indication that we're actively listening, right? But I would love to hear people's thoughts on have you had issues with nonverbal communication? Have you had successes based on nonverbal communication? Is anybody who would like to share about that? Ameza?
I want to share some difficulties I have had with non-verbal communication. I live in a part of the country, the northern part of the country, Kaduna State, where sometimes women cover themselves. Okay, so I've had issues where a man brought his wife, and sometimes you get couples like that, the male being the dominant couple and the woman, the wife being really recessive, and this woman was abusing this codeine or cough syrup, this opioid this thing. So and she was abusing it, and the husband brought her, and the husband was doing all the talking, and the wife was covered up. I couldn't even see her face, so I can't get her expression.
Mm-hmm.
I could not determine whether. So it was quite a challenge, which I'm afraid to say that was not really resolved because I could not get the husband to stop talking so that I could talk to the wife.
Right.
And I couldn't get the wife to open up, I mean, even remove what she was covering. So we didn't really make much headway in that encounter.
What a great example, because, you know, of course, I'm immediately talking about, as the clinician, our nonverbal communication, but what if you can't, you know, what about reading the nonverbal communication in a situation like that? That's absolutely, yeah, very challenging. Thank you. Has anyone ever made a mistake with their nonverbal communication? Had a really expressive face that they didn't mean to?
Yeah, hello?
You back, Fatima? We lost you for a second.
Yes, somebody was calling on. So, like Omeza said, we are in the same state, but different towns. In fact, Omeza is even in the town. It's in the urban area, while I am in the village, sort of, maybe semi-urban. And here, you know, if it was a counseling relationship, I would have said this is a case of a counter transference or transference, one of the two. You know, when I first came to Zaria, a man came into my office and then he went back. You know, just into my office and went back, and I said, what's the problem? Can you call me that? What's the problem? He's wearing trousers and a fitted top, a fitted blouse. I said, so what? So here in Zaria, a woman is expected to cover up. A woman is expected to cover up the head and everywhere. So the man was not comfortable with me. So after some times, you know, if I had a client that will be coming tomorrow, sometimes I will just cover myself, you know, pretend that. Okay. I'll just cover myself up because some people here find it very indifferent, you know, for a woman to they properly dressed, you know. So sometimes this is a problem on the job too, especially in this kind of rural area here. Sometimes when you are talking to some of them, you find that the client is looking at you, you know, with some kind of, the client is looking at you and you'll be feeling the eyes on you.
Sure.
It's really it's a serious issue around this place.
Right, and then that distracts from the purpose of the session. So thank you. I appreciate that. Easy, did you want to share something?
Hello? Hello?
Yes, Titi?
No, we are here.
Yeah, I can hear you.
All right. Now you're talking about nonverbal. I know I do once have a client like that. And in the course of our talking, you see him doing, you know, you feel uncomfortable. We are having, this is a therapeutic relationship. And your client is a male doing.
Ooh, that's a new one on me.
So sometimes you feel uncomfortable. This is I'm trying to have a relationship, and now now another feelings is coming in. So oftentimes I will remove my eyes, and the same thing will come over again. So the best thing, I'll just say, okay, can we just end this section? Maybe we'll fix another time.
That is a new one on me. Thank you. So Jackie is having connection issues, but she shared something that I really want to read. So she says, there's a rule that communication is only 7% verbal and 93% nonverbal. The nonverbal component is made up of body language and tone of voice. How you communicate nonverbal can help to put someone at ease and build trust or confuse and offend. These are lessons I've learned in the course of practice. So that's really great point. You know, and some of it is, we talked last time about if I'm sitting at my desk like this, paying attention to the computer, right? I may not be looking at them like, what's wrong with you? But are they going to feel that I'm listening? Are they going to feel heard or cared for? No. If my attention is at the computer, or if, you know, maybe I'm having a rough day, so my mind, you know, my face is looking like something is wrong. So it's really important that, you know, and it goes, I'm always going to remind you about your self-care. So maybe you have to take a few minutes before a session and just do some deep breathing, or take a short walk, or freshen up, you know, whatever it is, so that when you're ready to be with that person, you're ready to be with that person. And as was mentioned, then you're able to have the right tone of voice and the right look and give them your attention. Or we've talked about this, say something like, I really have to take notes while we're talking. You know, you know how it is, you know, work, you know, that kind of thing. And, you know, at least you're showing that I am listening to you, and maybe I'm just nodding when you say things, or I'm giving you a little smile, or, you know, have you ever talked to someone and you think you're being kind of charming and witty and they're not responding at all? Yeah. So, you know, they're either they're not really listening, or they're not really engaging in what you're saying. And we don't want our clients to feel that way. It's so critical. And as, you know, Jackie said, only 7% verbal. Well, I would also argue that most of the verbalizations in the session should come from the client anyways, right? So we should be doing a lot more listening, maybe asking some questions, redirecting, you know, but that's another thing to keep in mind that isn't stated here per se. We'll talk more about it when we talk about group sessions, but it's not for us to be talking as much. So our nonverbal becomes even more important because we're nodding, or we're looking them, you know, in the eye if that's appropriate, or we're showing them in some way that we really hear what they're saying and that we really care. And that if they say something upsetting, we're having, you know, an empathetic face or whatever is appropriate. So Great. Any other questions or comments on nonverbal communication? I don't know the answer to Omeza's challenge. I don't know if anyone has any ideas in that case, because again, we have to be culturally appropriate. Dr. Godlove, you want to share something? You want to respond to that?
I just wanted to say that even back in my culture, non-verbal communication is very important. But it's also helpful that if you sense, I do that a lot, if I'm not sure how I'm communicating non-verbally, I can check it out. And if I also sense that from a client, I'm talking like our friend talk about sign, the person sign. Sometimes it's good to take risk to check out, am I coming across, is there something I'm doing wrong? I tend to see you sigh as I speak, and I'm not showing what I'm doing wrong. I've checked that out, and sometimes it might not even be the client. It might not even be about you. It might be something that the client is struggling with. So I have risk doing that, and that has helped a lot, even in my culture, where sometimes people go with a lot with the assumption. I have to try to check it out, to find out how am I communicating non-verbally, and if I sense that with the client, also check, say, I see you do this. What is that all about? Thank you.
I really love that. And again, it goes back to what was said earlier about this is maybe one of the only healthy relationships that the client has, right? Like Shigeo said earlier. So to be able to say to them, yeah, I noticed that you seem tense when I'm saying that, or that you're sighing, or that you're nodding, or, you know, whatever it is, so that the person can realize, you know, maybe they don't even realize they're doing it, or maybe they can give you, as you said, some feedback. You know, is there something that I'm saying that is disturbing, or that you agree with, or, you know, so that's a really great idea. We're kind of shining a mirror, right? That's what we want to do as part of our relationship, is to be a mirror to the person. You know, this is what I'm seeing. This is what I'm hearing. Is that what you mean to communicate? Yep, great. So I want to just kind of summarize some of what, Shigeo, go ahead.
Sometimes when I'm trying to teach this kind of skills or topics, I like to explain a little bit of the projective identification. It's a very like a psychoanalytical concept, but it's very common in practice, because I know what I see in many very young or students is that they get confused about projective identification. Is when the client have an emotion, right? And that emotion is like they project to you, to the counselor, and you're the counselor. If you're not aware of your inner emotions, you may act this emotion that isn't about you, and then it's going to be very hard, very difficult. So I try to step out this concept, because it's very useful, not just for counseling, but many areas. So that's a way to stop a wrestling, a fight situation with the client. So I know, I think it combines non-verbal communication, it combines transference, transference. So that I wanted to add this comment.
Could you please give an example? So if I'm the client and I don't know what I would be doing, but how would you?
Well, it comes to my mind. I work a lot with child and adolescents. So I work with the didactic with mom and son, right? So many times the mom is going to push me a lot, being very hard, or the mom feels very frustrating because she is seeing that his son is very upset, that it has been 1, 2, 3 weeks and still have these mood swings, still are consuming, etc. And when I look at their developmental history, they are very a family that doesn't take responsibility to their own son, you know. But they are trying to be very, how do you say, exagerados, how do you say in English? They're trying to get the best of the medical or health institute, but they don't do their own minimal things. Yeah, so I feel like some kind of mad at that point, but then at that point I take conscious and say, okay, that's not my angry, that's the angry of the mom. So I know it's kind of that situation, that example.
Yeah, no, I love it. Thank you. Thank you. Yes, I appreciate that. And I not a concept that we brought in, you know, obviously in the text. So I appreciate you introducing that. So just to make sure that we have enough time, I just want to jump into wrap up and what we have for next time. First of all, I should ask, is everyone good for 2 weeks from today at the same time? So that
yes.
Okay, so that would be the 26th.
Yes.
I won't even say a time because we're all in different times. Yeah. So.
Okay.
Okay, and what I'll do in between, as I've done in the past, is I will send you the assignments, just even though you can look in your manual, but just to highlight them. And the other thing I want to mention, in case you didn't notice, is that on our forum on ISEP, which hopefully you're going to, I know some of you are using it a lot, thank you. The recordings from our last 2 sessions, our skill module 1 and our orientation, are both on there. So if there's anything you want to look back on, if you missed anything, if your connection was poor, it's all there under the videos tab. So please, you know, help yourself to checking that out. And so just to wrap up today, we talked about, we did quite a bit. Thank you guys so much. We've talked about purpose of counseling, the empowerment in the relationship, the self-disclosure, how and when that's appropriate or not. We went into dual relationships, transference and countertransference, as well as nonverbal communication. So we did a lot. I really enjoyed the role play, and I'm grateful to our participants for doing that. I know that's not always comfortable, but you did a great job. And for next week, we're going to be talking about implementing the core skills of addiction counseling. And I think you'll all really enjoy it. I know some of you are fans of motivational enhancement. Some of you mentioned maybe needing some help with things like rolling with resistance. And this is, I actually literally have a crush on a person who is my trainer for motivational enhancement. It's like my favorite thing. So I've done trainings around Florida on motivational enhancement. So I think this will be really great, and we can practice, and we can, you know, you can challenge me, and, you know, I think it'll be excellent, and you'll leave with a lot of skills, which I hope you feel that today as well. So yeah, so I will send all that to you, and we will meet on what will be June 26th at the same time. So we have a couple minutes left if anyone has questions or comments. That is all I have for today. Does anybody have anything they want to say?
Yes, I want to say something.
Yes, please.
I want to say that I love this group, and everyone has been doing so very well. And thank you to Kerry for being a good mentor. We love what you are doing. Thank you, everyone, for being resilient too.
Yes.
Thank you.
Thank you. Yay.
Thanks for letting me participate. This was really great. You all have really hard jobs.
Very true. Thank you,
you.
Charlotte. Appreciate that.
I hope the network was quite poor this time. I hope next time it will be better. It's not something we can control. But hopefully we'll get a better deal next 2 weeks time.
Yeah. But thank you to everyone, as Fatima said, for being resilient and being flexible, which I know you always are. And some things are outside of our control, right? Dr. Peters, did you want to say anything before we?
No, it's just thanks for letting me sit in. Of course, this is a project Carrie and I have been involved in, along with Nathalie and Charlotte and the group INL. So I'm really proud of all the work that you're doing. It's challenging to be part of these sessions in a virtual environment, but what a wonderful session that I sat in last time for the session as well. So congratulations on the great work that you're doing, and to Carrie as well. It's a really fantastic group. I really enjoyed it this morning.
All right. Thank you. All right.
Thank you.
Go forth and do good work. Thank you.
Thank you. Bye.
Thank you, everyone.
Bye.
Bye-bye.
Hey, everybody.
everyone.
Thank you, Titi. You're so sweet. I appreciate you.